This hearing will come to order. Good afternoon and welcome to the Budget Committee's hearing on health and wealth inequality in America, how COVID-19 makes clear the need for change. I want to welcome our witnesses here today. At the outset, due to the new virtual hearing world that we're in, I ask unanimous consent that the chair be authorized to declare a recess at any time to address technical difficulties that may arise with such remote proceedings. Without objection, so ordered. As a reminder, we're holding this hearing virtually in compliance with the regulations for committee proceedings pursuant to House Resolution 965. First, consistent with regulations, the chair or staff designated by the chair may mute participants' microphones when they are not under recognition for the purposes of eliminating inadvertent background noise. Members are responsible for unmuting themselves when they seek recognition or when they are recognized for their 5 minutes. We are not permitted to unmute members unless they explicitly request assistance. If I notice that you have not unmuted yourself, I will ask you if you would like staff to unmute you. If you indicate approval by nodding, staff will unmute your microphone. They will not unmute you under any other conditions. Second, members must have their cameras on throughout this proceeding and must be visible on screen in order to be recognized. As a reminder, members may not participate in more than one committee proceeding simultaneously. Now, I will introduce our witnesses. This afternoon, we will be hearing from Professor Sir Angus Deaton, Senior Scholar at Princeton University Woodrow Wilson School and Presidential Professor of Economics at the University of Southern California. Dr. Patrice Harris, immediate past President of the American Medical Association. Dr. Damon Jones, Associate Professor at the University of Chicago Harris School. And Mr. Avik Roy, President of the Foundation for Research on Equal Opportunity. I will now yield myself 5 minutes for an opening statement. The word unprecedented is often overused, but right now, what we are facing as a nation and a society is truly unprecedented. We are simultaneously battling a global pandemic as the coronavirus rages on, an economic free fall from business closures and waves of mass unemployment, and a crisis of conscience as we grapple with the deadly effects of entrenched systemic racism in our country. Nearly every American has experienced uncertainty and far too many extreme hardships during the last several months. But these crises have something else in common. They all disproportionately impact Americans of color. Today, the Budget Committee will examine one aspect of this: economic inequalities that have exacerbated COVID-19's impact on our minority communities. Historic and persistent racial disparities in income, employment, education, wealth, healthcare, housing, and more have made Americans of color more vulnerable to the virus, both in terms of health and economic status. Nowhere is the disproportionate impact of coronavirus clearer than in the virus's death rates. If Black and Latino Americans died of COVID-19 at the same rate as white Americans, at least 14,400 Black Americans and 1,200 Latinos would still be alive today. While the CDC may not list structural racism as one of the chronic conditions putting people at a higher risk for severe COVID-19 disease, long-term health inequities and barriers to accessing quality, affordable health care have made communities of color more vulnerable to serious illness and death from coronavirus. Where you live, where you work, and how you get to work all influence health status and outcomes. And more often than not, it's to the detriment of Black and Latino families. These long-standing inequities are only hard to see if you refuse to look. And when it comes to economic justice, the facts are plentiful. In terms of median household earnings, the most recent census data shows that for every dollar a white family earns, a Latino family earns 73 cents, while a Black family earns just 59 cents. Decades of income inequality and the resulting wealth gap have left Black and Latino Americans with less savings and far less ability to weather a serious health emergency or economic crisis. Today, families are battling both. The same households that had less going into this economic crisis have faced far more layoffs and job loss. While all groups have seen a historic rise in unemployment compared to pre-pandemic levels, the May 2020 unemployment rates for Black and Latino Americans were substantially higher than for white Americans. The pandemic has redefined essential work And while Black and Latino workers compose 29% of the national workforce, they account for 34% of frontline workers. Every day, they are forced to choose between their health and a paycheck. Despite this, many of these workers still do not have access to paid leave or hazard pay, and more than 1 in 4 frontline workers have said the coronavirus has made it harder to meet their basic needs. But workers aren't the only ones whose daily life has been upended. The coronavirus has led to widespread school closures across communities, and children of color may be impacted the most. One study estimated that while the average white student may lose about 6 months of learning, the average Latino student may lose 9 months, and the average Black student may lose 10 months. Without action, this could exacerbate graduation rates disparities among students of color, further perpetuating economic inequality for generations to come. The COVID-19 pandemic has exposed the cracks in our systems and laid bare the underlying inequities that have existed in the United States for generations. In our healthcare system, our economy, in education, and in our justice systems. It threatens to widen the economic chasm between white Americans and Americans of color. If not contained and reversed, we will not only jeopardize the future of millions of American families, we risk the well-being of our nation. As we look forward to the next phase of recovery efforts, we must strive for structural change that will not only help our economy recover, but also help more people, specifically people of color, prosper when it does. We cannot be foolish enough to think that a rising tide will lift all boats. If we are, we will sink the country. This has to be a turning point. There is too much need, too much pain, and too much anger for Congress to do little or nothing. I know we cannot end institutional racism overnight, but we can certainly start. We can build a stronger nation, a more inclusive economy, and an America that better reflects our values. And that is what I hope to focus on today. Now yield 5 minutes to the ranking member, Mr. Womack, for his opening remarks.
I thank the chairman, and thanks to all of the members of the committee for participating today. It's great to be in this hearing. Prior to the coronavirus, the U.S. economy was increasing wages and living standards. Median average income adjusted for inflation increased by 3.4% in 2018. Poverty rate fell from 12.3 to 11.8%. According to the latest Census Bureau data. Unemployment was at a 5-decade low of 3.5%. Black, Hispanic, and Asian unemployment rates fell to 5.4, 3.9, and 2.1% respectively, all of which were record lows. Wages were growing faster for low-income workers than for higher-income workers, but the pandemic, as we all know, brought these upward trends to a screeching halt. While I think the topic of today's hearing is extremely important, and one that we need to carefully discuss and address, I'm concerned that this committee ought to be focused on a large and growing crisis that threatens income security programs for all Americans. And that threat is our out-of-control deficit and debt. Congress has, and I might add appropriately, and on a bipartisan basis, enacted $2.5 trillion worth of legislation to address our current public health and economic crisis. Even while we take such unprecedented action, we can no longer ignore our country's long-term fiscal imbalance. The nation's structural budget deficits, which exist not only in economic emergency, but also during peace and prosperity, are a severe challenge to the critical programs that millions of our seniors and low-income Americans rely on every day, like Social Security, Medicare, Medicaid, and that list goes on and on. The federal government's future ability to fund these programs is under a real threat by the growth of net interest payments, which are growing far more rapidly than the rest of the federal budget, even with historically low interest rates. Ultimately, if we fail to live up to our duty to responsibly budget, future generations may face a sovereign debt crisis that would not only threaten our ability to fund these programs that tens of millions of Americans rely on, but would also cause economic hardship for all Americans. And let me just add, too, that the pressure on the discretionary budget of the United States Congress speaks for itself with deficits and debt the way we are calculating them today. Since we failed to do our job during normal times and put the nation on a fiscally responsible path, We set ourselves up for an even more challenging budget outlook when the pandemic crisis hit. Now, our deficit this year is projected to be just under $4 trillion, by far the highest in American history. This committee needs to get back to its job of writing a budget resolution for Congress and making the tough choices we've been tasked to do. It's not going to be easy. Indeed, it's going to be much more difficult with a pandemic, but it needs to be done. This is the only way these critical safety net programs so vital to our most vulnerable communities, will continue to exist for current and future generations. The past few months have been extremely challenging for the entire country and, in fact, the entire world. In the United States, over 2 million cases of COVID-19 have ravaged the health of our nation, and our economy has been infected as well. The economic downturn caused by the quarantine orders has significantly increased the impact of COVID-19 on our most vulnerable. Today, we will discuss how the pandemic has exacerbated pre-existing healthcare and economic inequalities in the nation. So I look forward to today's discussion. And Mr. Chairman, again, I thank you for hosting the hearing today, and I look forward to it. And I yield back the balance of my time.
Thank the ranking member. Would also, once again, like to thank our witnesses for being here this afternoon. The committee has received your written statements, and they will be made part of the formal hearing record. Each of you will have 5 minutes to give your oral remarks. As a reminder, please unmute your microphone before speaking. Dr. Angus Deaton, please unmute your microphone. You may begin when you are ready. You're recognized for 5 minutes. Thank you for being here.
Chairman Yarmouth, Ranking Member Womack, and committee members, thank you for inviting me to talk about the inequalities in the COVID-19 pandemic. The pandemic is exposing and exaggerating long-standing inequalities in health and wealth. It will worsen the inequalities between Black and white, between the more and the less educated, and between ordinary people and the well-off. Enlightened policy can moderate these effects, as has already been the case, but we are not done. The pandemic may turn tolerable inequalities into intolerable inequalities. There is a danger of social unrest, but there are also opportunities to address old problems. The need to repair our policing has already become urgent. Other outstanding issues include healthcare, antitrust policy, and our system of unemployment benefits. In the past half-century, the lives of Americans have become increasingly divided according to whether or not people have a 4-year college degree. Those with a BA have prospered and are living longer, while those without are floundering. Not only are the gaps widening, but the lives of less educated Americans are getting worse. The American economy is not delivering for less educated Americans. In our book, Deaths of Despair and the Future of Capitalism, Ann Case and I document this disaster. Mortality rates have risen, driven by rapid increases in deaths of despair, suicides, overdoses, alcoholic liver disease, and an uptick in deaths from heart disease. At the same time, wages and employment have declined, as have marriages, socializing, and church-going. In all of these areas, more educated Americans continue to make progress. The disintegration of white working-class life parallels an earlier disintegration among African-American communities in the 1960s and 1970s, culminating in the crack epidemic. African-American mortality rates have long been higher than those of whites. The gap has diminished steadily, closing particularly rapidly when white mortality rates began to rise in the mid-1990s. This convergence came to a halt after 2013, when fentanyl deaths among blacks were BA were largely exempt. American healthcare played a role in the disaster. Pharmaceutical companies were largely responsible for the first wave of the opioid epidemic. The exorbitant cost of healthcare, much of which is financed through employment, has lowered wages and destroyed good jobs for less educated Americans. At the same time, it is expanding wealth inequality. This was before the pandemic. COVID death rates are higher for African Americans and Native Americans than for whites, occupation, segregation, population density, transportation, and the patterns of pre-existing health conditions are all involved. High incarceration rates for African Americans have brought excess mortality from COVID. Lives of the more educated are less at risk because many of us can work and earn while social distancing. Poorer kids are likely to do less well with internet classes. The pandemic has exposed the folly of tying health insurance to work. African Americans and Hispanics were less likely to have insurance pre-COVID, and they and the millions who became unemployed find themselves at risk. Temporary arrangements are covering COVID-related healthcare, but they are not sustainable. America needs what other rich countries have, healthcare that is not tied to employment, that covers everyone from birth, and that controls costs. Our patchwork state-based system of unemployment benefit is also being exposed by the pandemic. Many have been concerned about consolidation and growing market power of large firms, prices rising faster in the US than in Europe, and the falling share of labor and national income. COVID has shuttered many businesses, increased the power of big tech, and will cause further consolidation. Reinvigorating antitrust enforcement was a priority before and will be urgent afterwards. The 4 largest states have a third of the population, but only 8% of the votes in the Senate. COVID victims are even less well represented. Half of all deaths have only 8% of Senate votes, an inequality that will narrow as the epidemic moves into rural America. Unequal political representation in a pandemic serves further to divide us. Thank you.
Thank you, Dr. Deaton. Now I recognize Dr. Harris for 5 minutes. Please unmute your mic, Dr. Harris.
Thank you. Good afternoon, Chairman Yarmouth, Ranking Member Womack, and committee members. The American Medical Association commends you for holding today's hearing. My name is Dr. Patrice Harris, and I am immediate past president of the AMA. I am a practicing child and adolescent psychiatrist from Atlanta, and thank you for the opportunity to testify today. As our nation confronts a dual crisis of a deadly pandemic that has triggered economic instability and joblessness unseen since the Great Depression, inequities have been starkly revealed, most notably among Black Americans, the Latinx community, and Native American communities. And I would like to highlight just a few facts. Black Americans have been among the hardest hit population by this virus. Not only are we hospitalized and dying in disproportionate numbers, we also are more likely than white Americans to have lost income because of the pandemic. In 42 states, plus Washington, D.C., Hispanics and the Latinx community make up a greater share of confirmed cases than the share of their population. In 8 states, it's more than 4 times greater. The death rate in the Navajo Nation is higher than in any single U.S. state. So clearly, COVID-19 is having a disproportionate impact on minoritized and marginalized communities. And why? Structural inequities that result from long-term policies, practices, and procedures that determine access to comprehensive health care, as well as those determinants of health, inadequate housing, education, food insecurity, and these are all influenced by bias and racial discrimination. Higher prevalence of chronic health conditions such as diabetes, hypertension, asthma, and obesity. An increased likelihood of working essential jobs such as bus drivers, train operators, those who are working in our supermarkets and meat packing plants, hospitals and nursing home, and of course that increases the risk of exposure. A stronger likelihood of living in congregate multi-generational living arrangements, and major mistrust of medical institutions because of historical abuses of science and research, and of course, misinformation and disinformation. So the AMA is very concerned that the pandemic and the economic fallout will further exacerbate these long-standing and long-term health, economic, and social inequities experienced by minoritized and marginalized communities. Now, these dual crises are also having an impact on our collective mental health. The toll is not yet known, but I will tell you that people are angry, exhausted, and frustrated. And in nearly every community, people are demanding change. New data from the Household Pulse Survey should suggest that COVID-19 is worsening mental health for communities of color, which as a group have less access to mental health services. As a child and adolescent psychiatrist, I worry about the short-term and the long-term mental health impact this pandemic will have on our children, particularly our children of color. The AMA is deeply committed to achieving greater health equity by raising awareness about its importance to patients and communities and by working to identify and eliminate inequities. The good news is we are talking about it. The public is more aware. We are having this conversation today. So we must use this opportunity to move our country forward on health equity through change at the individual level in our policies and procedures and in our culture. And how do we move forward? Briefly, some suggestions. We have to address implicit and unconscious bias at all levels and at all systems. We need targeted outreach on COVID-19 testing. We need to make sure that vaccine trials include a diverse population. We need federal and state agencies to collect and report COVID-19 data on infections. We need support for increasing diversity of the medical workforce. We need a national strategy with state partnerships for increased resources for a mental health infrastructure that has for decades gone under-resourced and underfunded. And we need to expand access to health insurance and high-quality health care. We cannot go back to business as usual. We must work together to build a society that supports equitable opportunities for optimal health for all. Thank you.
Thank you, Dr. Harris. And now recognize Dr. Jones for 5 minutes. Dr. Jones, thank you for joining us. Unmute your mic, please.
Thank you, Chairman Yarmuth and Ranking Member Womack for having me. I'm Damon Jones, an economist and an associate professor at the University of Chicago, Harris School of Public Policy. My research and teaching focus on inequality, tax policy, and household financial well-being. My comments today will focus on 4 aspects of inequality in the U.S. and how they interact with the current COVID-19 pandemic. I will begin with the well-documented decline in the individual and collective leverage of workers relative to their employers. Unionization rates have reached record lows, and recent research has highlighted market power by employers, which allows them to suppress worker pay. These developments have coincided with stagnant wages for the typical worker. It is in this context that we now find frontline workers in between a rock and a hard place. On the one hand, they have an opportunity to continue working when many others are forced into unemployment. On the other hand, they are being asked to risk exposure to COVID-19 infection. And the erosion in worker power I just mentioned leaves them unable to command adequate protection equipment, paid sick leave, or hazard pay. To paraphrase economist Rhonda Sharp, though these jobs are deemed essential, the workers who perform them are being treated as anything but. My second point will be quite brief. By linking one's insurance coverage to one's employment status, the U.S. is in the minority among its peer OECD countries. The flaws of this system are made painfully clear as we undergo historically rapid spikes in unemployment, thrusting millions into the ranks of the uninsured. During both a public health crisis and a recession, many are dreading the potential of enduring long-term unemployment and chronic health complications related to COVID-19 infection, all the while with limited access to healthcare. Next, let me turn to wealth inequality. Many households lack adequate liquid assets, which I define as cash on hand or assets that can be easily converted into cash. The typical household has less than 1 month of income saved up for a rainy day, meaning leaving many in a state of financial precarity. In recent research, my colleagues and I have shown that when faced with an unexpected cut in pay or a job loss, households with the least amount of assets have to cut spending on necessities by 2 to 4 times as much as their wealthier counterparts. During the current pandemic, millions of families find themselves in this very position. While payments via the CARES Act and extensions to unemployment insurance have filled the gaps for many, there remain households who have experienced delays in receiving relief. And there are others, people experiencing homelessness and undocumented people, who are unlikely to receive payments or who are outright excluded from these benefits. I will end with the issue of racial inequality. In the above three instances, the patterns of inequality are strongly predicted by one's racial and ethnic identity. Black workers make up a disproportionate share of frontline workers, and Latinx workers are overrepresented in key frontline industries. Insurance coverage is lower for people of color, especially Native families, relative to white ones. And the disproportionate increases in unemployment among these groups is likely to exacerbate this gap. The typical white household has between 9 to 10 times as much wealth as their Black and Latinx counterparts. Our research shows that this racial wealth gap leads Black and Latinx households to have to cut spending significantly more than white ones when faced with a reduction in pay or a job loss. Given the above discussion, I recommend a committee consider the following policies. First, protect workers' right to engage in collective bargaining, strengthen and enforce existing U.S. labor standards, and during the pandemic, convene bodies with representation from both workers and employers to address ongoing concerns of workplace health and safety. Second, in the short run, expand Medicaid eligibility for those who have experienced job loss. In the longer run, transition to a system of universal healthcare provision and health insurance coverage. Third, continue extensions of the unemployment insurance program beyond their expiration at the end of July. Tie this continued renewal to macroeconomic indicators and disperse additional periodic direct payments to households through the IRS. Provide resources to state and local governments to better reach individuals not covered by either of these previous two channels, and extend relief to undocumented families. Finally, the racial disparities I have summarized are driven by long-standing factors, such as historical and structural racism. They therefore require more fundamental interventions. As an example, we should move forward with HR 40 and establishing a committee to explore reparations for African Americans. Such policies directly address racial inequality by moving toward what William Darity Jr. and A. Kirsten Mullen describe as acknowledgement, redress, and possible closure with respect to historic racial injustice. Thank you, and I look forward to your questions.
Thank you very much, Dr. Jones. And now I yield 5 minutes to Mr. Roy. Welcome to the committee, Mr. Roy. Thanks for being with us.
Thank you, Mr. Chairman, and also to Ranking Member Womack and members of the committee. Thanks for inviting me here today. The Foundation for Research on Equal Opportunity, or FREOP for short, is a nonpartisan think tank that focuses exclusively on ideas that can improve the lives of Americans on the bottom half of the economic ladder. I welcome the opportunity to discuss our work on how COVID-19 economic lockdowns have widened racial inequities in education, health, and the workforce. My written statement contains a more detailed discussion of our findings. In my oral remarks, I'll focus on 3 topics. First, I'll discuss how economic lockdowns imposed by states and localities have disproportionately harmed minority employment and minority-owned businesses. Second, I'll touch on how economic lockdowns have further destabilized the fiscal sustainability of the United States. Third, I'll discuss how COVID-19 mortality by race and ethnicity and how states' failure to protect nursing homes in particular has harmed vulnerable seniors of all races. As Mr. Womack noted, in late 2019, Black unemployment reached its lowest rate in history, 5.4%. Today, the Black unemployment rate is 16.8%. Hispanic unemployment rate was 3.9% in late 2019. Now it's at 17.6%. In my written testimony, I detail how disparities between white and non-white unemployment rates also reached their lowest levels in history prior to the pandemic. But the economic lockdowns have brought those disparities back to levels last seen a decade ago. Compared to whites and Asians, Blacks and Latinos are less likely to work in white-collar occupations where working from home is feasible. Instead, they are seeing their jobs and hours slashed. Hourly wage work is down 50% on average, and even more in places with the most stringent lockdowns. But Black-owned businesses have also been hit far harder than white-owned businesses. It's estimated that Black-owned businesses have experienced losses of 41% between February and April versus 32% for Hispanic-owned businesses and 17% for white-owned businesses. Put simply, racial and ethnic disparities are worse when the economy is worse, and especially during the government-mandated shutdowns of the economy we're experiencing today. As you know, the CARES Act and related legislation has increased the federal deficit by trillions of dollars. Material increases in the federal debt further destabilize what is already a dangerous situation. If demand for U.S. Treasury bonds declines on account of decreased U.S. creditworthiness, such that Congress must enact substantial austerity measures, it will be low-income Americans who bear the greatest burden. Higher taxes resulting in shrinkage of the economy will harm economically vulnerable Americans through rising unemployment. Second, reductions in federal spending will most harm those who most depend on that spending, such as Medicare and Medicaid beneficiaries. Hence, it is essential that Congress consider ways to pay for the recent COVID relief packages and also avoid further destabilizations of the federal budget. One rising concern is how COVID-19 is affecting different racial and ethnic populations. The latest data from CDC indicates that Blacks represent a greater share of COVID deaths than they do of the general population, even when adjusted for the fact that COVID is more prevalent in cities. Mortality rates are also higher, as has been noted by others, in Native American communities, especially in Arizona and New Mexico. What may be surprising is that whites are also dying of COVID at higher than predicted rates. On the other hand, Hispanics and Asians represent a lower share of COVID deaths than would be implied by their geographically adjusted share of the US population. The likely reason for these differences is that morbidity and mortality from COVID-19 is most common among the elderly. 81% of all COVID deaths in the US have occurred in people aged 65 or older, and whites are the oldest racial group in the US with a median age of 44. Asians have a median age of 37, Blacks 34, Hispanics 30. Hence, we should expect to see higher fatality rates in whites versus Asians and Hispanics due to their age, and we do. On the other hand, African Americans are also relatively young, but we are still seeing higher mortality among Blacks. Some of you are familiar with our research on the tragedy taking place in our nursing homes and assisted living facilities. 0.6% of Americans live in long-term care facilities, and yet within the 0.6% of the population lies 43% of all deaths from the novel coronavirus. 43%. As you know, nursing homes are residential facilities for medically vulnerable seniors who have challenges with activities of daily living, such as taking a shower or getting dressed. Nursing homes are disproportionately poor, non-white, and enrolled in Medicaid. The nursing home tragedy has a bronze lining, if you will, because it means that the risk of death from COVID for the rest of the population is considerably lower than we may have thought. We can use that information to reopen the economy and reduce the harm we are imposing on hundreds of millions of Americans of all colors. Thank you.
Thank you for your testimony, Mr. Roy. Thanks once again to all the witnesses for their testimony. We will begin our question and answer period right now. As a reminder, members can submit written questions to be answered later in writing. Those questions and the witnesses' answers will be made part of the formal hearing record. Any members who wish to submit questions for the record may do so by sending them to the clerk electronically within 7 days. As is our custom, the ranking member and I will defer our questions until the end. So I now recognize the gentleman from New York, Mr. Higgins, for 5 minutes. Please unmute. Okay. Would you like the staff to unmute you? Just nod. Thanks. I think you're good to go.
All right, thank you very much, Mr. Chairman, and thank you, panel. Just a couple of thoughts here, first and foremost, and that is that 120,000 Americans are dead, and we have a government lockdown of the American economy because the federal government failed to protect the American people. We have a highly infectious, contagious disease that attacks the lung, the liver, and the heart. And the best thing that our fragile healthcare system can do for people suffering through the symptoms of COVID-19 is to provide them with Tylenol to help break their fever and to help them with their pain. The United States is the richest country in the world. We pay more for healthcare than any other country, and we have no treatment and we have no vaccine. Dr. Harris, I think this is an appalling set of circumstances for our country and what has been done to the African American community with the higher than the percentage of their population cases of COVID-19, whether it's in Buffalo or any other city in this country, is very revealing and exposes the acute fragility of the American system. Now, I've heard Dr. Fauci, who probably is the most credible public health official, say that he is optimistic about the possibility of a vaccine at the end of this year. That's about 8 months from when we discovered this. From what I can tell, the quickest development of a vaccine was by Merck in response to Ebola, which was 5 years. Do you, as a medical professional, the former head of the American Medical Association, share my concerns that what Dr. Fauci is saying and what people hear are two different things? I'm concerned when he advances that optimistic view, perhaps overly, of having a vaccine by the end of this year. What people hear is that they can become complacent about the things that we're doing now: social, physical distancing, face masks, and personal hygiene. I'd like to get your thoughts on that.
Sorry,
Please
I'll
unmute,
start
Dr.
again.
Harris. There.
Yes, sorry about that. Thank you, Congressman. And let me first say that, of course, Dr. Fauci is the foremost expert on infectious diseases in our country. And I want to parse a little bit what I hear Dr. Fauci saying as well. And I do think that there's certainly nothing wrong with being optimistic. But when Dr. Fauci, and you're right, that an end-of-year time frame is optimistic and ambitious, but certainly when you have an all-hands-on-deck approach, I know it's possible. But I also hear Dr. Fauci saying that a vaccine could perhaps be developed by the end of the year. And I think what this body knows is that is just the first step, is development. Then you have to manufacture, then you have to distribute, and you have to, of course, make sure that the vaccine is ultimately equitably distributed. So certainly, Dr. Fauci has information that I don't have, and certainly I would follow his lead when it comes to his timeline. But I also know that it will be important not just to develop the vaccine, but also get it distributed. And we have to make sure that there is a diverse population who's included in the clinical trials.
Okay, thank you. And just a final thought. It's like a tale of two countries. I represent Buffalo on the Canadian border. And the United States federal response to coronavirus COVID-19 was late, sloppy, and adversarial. The Canadian federal response was early, strong, and united. I'm trying to help get the U.S.-Canadian border opened up. And, we have been unsuccessful. I'm doing this with Elise Cusack, who's my co-chair on the Northern Border Caucus. Here's why. The entire province of Ontario, that includes Toronto, has 250 cases of COVID-19 for every 100,000 population. New York City has 2,576 cases for every 100 population, 10 times more. The reason we can't get the border open is because the Canadians in Ontario don't want Americans over there. Because given our high numbers, we are super spreaders. And again, I just think that underscores, I love optimism, but I want reality as well. And unless and until we develop an effective treatment and vaccine, there is no normalcy, not in terms of our healthcare and not in terms of our economy. With that, I'll yield back, Mr. Chairman.
All right, thank you. The gentleman's time has expired. I now recognize the gentleman from Georgia, Mr. Woodall for 5 minutes. Please unmute. Oh, I'm sorry. Hold on. I think Rob dropped out. I now recognize the gentleman from Ohio, Mr. Johnson, for 5 minutes.
Well, thank you, Mr. Chairman. Appreciate you holding this hearing, and Ranking Member Womack. I think it's an important hearing. Over the past few months, we've seen the devastating impacts of the COVID-19 pandemic on our communities, and we've also seen the positive power of deregulation when it comes to removing barriers to healthcare and stimulating our economy. And as we continue the long road to recovery, we must recognize the importance of deregulation and the need to continue removing unnecessary regulations that may inhibit economic recovery. I know in my district, we're already seeing the benefits of deregulation, especially when it comes to reducing barriers to telehealth access. The deregulation of telehealth during the COVID-19 pandemic has not only improved access to health care for my constituents in Eastern and Southeastern Ohio, but it also provided invaluable care for those in underserved rural areas across the nation. Deregulation has helped change the way health care is delivered. We saw it play out over the past few months. It's my hope that Congress will embrace more regulatory flexibility that will ultimately help in our economic recovery and lead to greater access to quality, affordable health care. So there is no question that this crisis has exposed the need for more health care reform, but the solution is certainly not to expand the Affordable Care Act, which has resulted in fewer choices and higher health care costs. The American people deserve better than a continuation of the ACA's broken promises, most notably the broken promise that it would reduce insurance costs, the broken promise that it would improve access, and the broken promise that it would increase patient choice. Future healthcare reform must be patient-centered. Americans need more choices when it comes to healthcare, and Congress should do everything in its power to prioritize a patient-centered, consumer-controlled healthcare system rather than an inefficient, expensive, government-run healthcare system. The American people deserve patient-centered, market-based reforms that'll strengthen the patient-doctor relationship and give patients the ability to choose how best to meet their healthcare needs. And I look forward to working with my colleagues on these important issues as Congress takes additional steps to mitigate the impacts of the COVID-19 pandemic. So, Dr. Roy, prior to the COVID-19 pandemic, the federal budget was unsustainable, with the debt rising uncontrollably. In your opinion, what effect does the rising federal debt have on low-income Americans?
Well, as I mentioned in both my written and oral remarks, Mr. Johnson, I'm very concerned that both the spending of the CARES Act and related legislation and also the declining tax revenue from the economic lockdowns creates a perfect storm, which is going to massively increase the deficit. And then that's going to push forward, meaning closer in time to us today, the fiscal reckoning that is sure to come with runaway federal debts. We're almost already at the point in which the interest on the federal debt exceeds what we pay for national defense. And when we get to a point where we have to cut back spending on Medicare and Medicaid because our bondholders leave us no choice, who is going to be most harmed? It's the people who most depend on those programs. Those who have high incomes, who can afford private insurance, will be fine. It's those that can't who will be most harmed.
Yeah, I agree. Continuing with you, Dr. Roy, according to your research, what have been the public health impacts of the lockdowns and the extended lockdowns on low-income and minority communities?
Well, that's an excellent question and one that doesn't get asked enough, Mr. Johnson. And what I'd say is that it's going to take us years to really know what the effects are. But what we can certainly expect is that there are going to be people who didn't get their mammogram or their prostate exam during the lockdown. And as a result, when their cancer does get diagnosed, it's too late to do something about it. There are going to be people who had a heart attack, but that heart attack went untreated. But we know that because the number of people who've gone into hospitals reporting heart attacks has declined precipitously during the lockdown. I could go on and on, but there are many, many different areas of public health where we ought to be concerned. And then there's just the overall effects of massive unemployment for a prolonged period of time and the effect that has on life expectancy and other public health measures.
Yeah, okay. Well, I have other questions. I'll submit those for the record, Mr. Chairman, but thanks, and I yield back my time.
Absolutely. The gentleman's time has expired, and now recognize the gentlelady from Connecticut, Ms. DeLauro, for 5 minutes.
Can you hear me? Wonderful. Oh my gosh. I've become a technological genius in all of this. Thank you so much. Thank you so much, Mr. Chairman, Mr. Womack, for this hearing, and to our panelists. Dr. Deaton, I wanted to ask you, along with my colleague, Susan DelBene, and Senators Michael Bennet and Sherrod Brown, I've introduced the American Family Act, that would take our child tax credit and essentially turn it into a child allowance by extending full eligibility to 1/3 of all children and families who earn too little to get the full credit. It increases its value and it delivers it monthly. The child tax credit is our nation's largest expenditure on children. And the recent data shows that the American Family Act would cut child poverty, that rate by about 2/5, the Black child poverty rate in 1/2, and Hispanic child poverty rate by 41%. What we do in the House passed HEROES Act, it contains a 1-year version of this policy that would provide $300 a month for young children and $250 for older children. In essence, the credit is fully refundable. You get $3,600 for young children under 6, $3,000 for older children ages 6 to 17. It's monthly installments indexed to inflation. My question is, you have spoken about the importance of family allowances when you were a young father. Help us, and can you please talk, yes, what it meant to you, what it might mean for families and for children in the United States in the short term and in the longer term as we look to deal with the issue of inequality, of poverty, and those whom are essentially the most affected about this today.
Thank you. Thank you very much. I would tend to defer to some of my colleagues on child poverty in the United States, but I know it's a huge problem and a great scandal. And it really is important, not just for the suffering it engenders now, but the suffering it engenders in the future. There's really good evidence that children who grow up in poverty tend to suffer throughout their lives as a consequence. You asked me of my own experience. I grew up in Britain, and I was a young widower when I was 29, and the child allowances that were paid to my 2 kids made the real difference for me between being able to go on and having enough money to put food on the table and look after my kids. I think it's not just children, but I mean, I think one of the things that Ben Case and I talk about in our book is that the social safety net in America compared with what's happened in Europe is very frayed in many, many places. And, you know, people on the other side, and I too, would say, well, you know, how are you going to finance that? And I think it's long past time for Americans to think seriously about a value-added tax, which they have in Europe. It's a tax that people don't mind paying very much. It also generates a lot of revenue. It's somewhat regressive in who pays it because everybody pays it. But the net effect when it goes to things like child credits and child tax credits and so on, and child benefits, is that it's extremely progressive. It also means that when you have something horrible happen, like has happened here, that kicks into place immediately in a way that it just doesn't in this country at all. So that we have a sort of automatic set of responses to bad times when they come. So I'm very much in favor of that sort of expansion and using a value-added tax to try to pay for it.
I would just say with the just remaining few seconds that I have, Dr. Dean, I think we're looking probably, it's unlikely that we're going to deal with a value-added tax. But I believe that what we can do is to look at and the child poverty rates and to take a look at how a child tax credit where we've got 1/3 of kids today, mostly African-American kids and Latino kids who are not eligible because their families make too little, but to try to do something that we might in a positive way move forward on because it's already in existence and we were just adding it to it. Thank you so much, and thanks to all of you for your testimony. I yield back.
Gentlelady's time has expired. I now recognize the gentleman from North Carolina, Mr. Holding, for 5 minutes.
Thank you very much, Mr. Chairman. I appreciate that. As pointed out, this virus and the statewide closures we've used to contain it have highlighted several inequities in access to child care and nutrition services. And not only are minority children more likely to depend on school food programs, but they're also more likely to have parents who work in the services industry and are unable to stay at home when schools close. And as we've seen, disparities in nutrition access are not just short-term problems. Over time, they lead to higher rates of comorbidities and chronic conditions that make minority communities especially vulnerable to viruses like the COVID-19. From the beginning of this crisis, nonprofits like the YMCAs in Raleigh and Charlotte have stepped up to address the nutrition and childcare gap and support underrepresented communities in their time of need. And over the past few weeks, the YMCA of the Triangle has served almost 50,000 meals to families across the region and provided child care programs to over 1,700 healthcare workers. In Garner, North Carolina, in my district, for the Poole Family YMCA has set up day camps for children and runs blood drives to assist the healthcare community. These assistance programs played an essential role in providing stability to minority communities that have been disproportionately affected by this national emergency. But despite the tremendous work that the YMCAs have done throughout the country, they have been left out of the federal assistance programs they desperately need. Under the Paycheck Protection Program, which Congress enacted specifically to help groups like this, affiliated organizations like the YMCA of Charlotte and the YMCA of the Triangle cannot access funds if they collectively employ over 500 people. And as a result, these two YMCAs have furloughed over 95% of their staffs and continue operating at a loss. So without immediate federal assistance, YMCAs across the U.S. will no longer be able to provide these invaluable community services. I'm strongly urging all of my colleagues to support an adjustment in our next round of the Paycheck Protection Program to ensure nonprofits like the YMCA continue to serve those in need. So my question to you, Dr. Roy, can you speak to the potential long-term effects of irregular access to food and child care in low-income communities, and how the federal government can best work with the private sector and nonprofits to bridge that gap?
Well, there's a lot of things to say about this topic. Let me highlight one thing that I mentioned in my written testimony, sir, which is that the closure of schools is a big disruptor in the delivery of nutrition to low-income children, because so many low-income children get their lunch through the federal school lunch program. So this is where the school closures interact with a lot of federal assistance, which flows through public schools, and why one of the reasons why it's important to reopen schools where it's prudently possible to do so. And we at FREOP are putting out a plan very soon on how you can reopen schools in a way that's consistent with public health.
Excellent. Thank you very much. Mr. Chairman, I yield back.
Yields back. I now recognize the gentlelady from Illinois, Ms. Chakowski, for 5 minutes. Please unmute.
There I am. Thank you very much, Mr. Chairman. And when I look at the name of this hearing, Health and Wealth Inequities in America, how COVID-19 makes clear the need for change. This could not be a more important moment to have this the discussion. We have seen so many, and you listed some of them, inequities that have really come to light because of this. I want to talk about one of the things that I worry about. 34 million Americans know someone who has died from not being able to afford the prescription drugs. But while 10% of white Americans know someone who has died because of that, 20%, twice as many of non-white Americans know someone who has died from being unable to afford treatment. Similarly, people of color are twice as likely as white Americans to consider high drug prices to be among our most pressing issue today. This was even before, well before we hit COVID-19, this was the problem. And yesterday, Representative Doggett and Representative DeLauro and DeFazio and Representative Rooney, bipartisan, and I introduced what we call the MAP Act, HR 7296 and HR 7288, which is called the TRACK Act, to prevent price gouging at this time of the COVID-19 virus, and prohibiting monopolies, that no one company can control the remedies for the vaccines, and to ensure transparency on taxpayer-funded COVID-19 drugs. So Dr. Harris and Dr. Jones, I'm wondering if you could discuss why people of color and Black Americans in particular may be severely or even fatally impacted by high drug prices, and if this is something that you see in your practices and your lives.
Am I unmuted? Can you hear me?
Yes.
Thank you. This is absolutely a critical issue, and that's why everyone needs to have access to affordable, meaningful health coverage, and that does include the ability to get help to pay for prescription medications. You ask about my own experience, and I have, over the course of my career, for those who had insurance, I've spent a great deal of my career working with children in the foster care system, or adults in the substance use disorders who relied on Medicaid or our state mental health system to pay for their services. And if they were able to access that, they were often not able to access the medications that I wanted to prescribe. And so as we move forward on making sure that everyone has access to affordable, meaningful coverage, of course, the affordability of prescription drugs has to be a part of that equation.
Thank you. So you wrote prescriptions sometimes that weren't filled, probably, right?
Yes, that is a significant problem.
Yep. Dr. Harris, Dr. Jones, did you want to respond?
Yeah, well, I would just add briefly that, another dynamic is that Black people in the United States and other people of color are less likely to have health insurance coverage. And so that's definitely going to introduce an additional barrier. And in terms of prescription drug prices, I think another thing to look at is how to make things more competitive. So how quickly can generic drugs be provided that can help to bring down the price of those prescription drugs once they're made available to the market?
Thank you. We're working on legislation. We've introduced legislation that would stop price gouging during this pandemic, because the pharmaceutical companies are prone to try and take advantage of a situation, but also to guarantee that any therapy or any vaccine that is discovered is affordable, and sometimes that may mean free, so that all Americans have access to that. I think we have to all accept that challenge and make sure all people will have access to the vaccines and therapies. So thank you very much. I yield back.
The gentleman yields back. I now recognize the gentleman from Pennsylvania, Mr. Buster, for 5 minutes.
Thank you, Mr. Chairman. Thank you all to the witnesses. Appreciate it. It's an important hearing. Our economy was in a good place, very good place, up until February of this past year. It had many benefits to the vast majority of Americans. Mr. Roy, let me ask you, the economy, the data from where we were come the beginning of 2020, the wage increases, levels of unemployment for all segments of the economy, for low income, for minorities, for rural areas, for our cities, always can be better. But would you say that we had some pretty positive trends that were beneficial to solving various inequalities that may have existed before?
There's no doubt, Mr. Muser, and as I mentioned in my opening remarks and also in my written testimony where I go into this in a lot of detail, the disparity between white and Black unemployment, the disparity between white and Hispanic unemployment reached record lows in late 2019. So we've made remarkable progress in reducing some of these disparities. And obviously the economic lockdowns have reversed a lot of those gains. And so the sooner we can get out of lockdown, get the economy back going again, maybe we can get back on that plane.
Yeah. And you know, I'm a Republican, but I'm always interested in a better plan. This might be a difficult question, but are you hearing anything so far in this hearing on health and wealth inequities that you think would be a pursuable for solving the inequity issue?
Well, the most important thing we can do to reduce inequities is drive economic growth. Right, so both in terms of reopening the economy and in general, pro-growth policies, a rising tide does lift all boats. That's what we've seen throughout the last several decades of the American economic experience. The better and stronger our economy is, the better it is, particularly for economically vulnerable populations. So I would highlight that in particular.
There was a $3.3 trillion HEROES Act proposed exclusively by the House Democratic caucus, no input from Republicans whatsoever. Was there anything in that would help these levels of inequality for health and wealth? I mean, you see election law changes as something that is dealing with this crisis. Do you think allowing state and local taxes being able to be deducted for over $10,000 is something important to create better equality within the society, particularly now as we're recovering from this crisis?
Well, I can't say that I've read the HEROES Act line by line, so you'll have to forgive me for that, but I am aware of several provisions that I've looked at more closely. One that I'm concerned about is a provision that would basically be a lottery for the trial lawyers to sue on behalf of anyone who was somehow connected, no matter how tenuously, to COVID-19, to sue their employer, sue the federal government, effectively get some sort of federal slush fund relief for injuries that may or may not be related to COVID-19. I was very concerned about that. And I'm also concerned about the restoration of tax breaks for high income individuals living in states with high state and local taxes. I don't understand why that's good policy.
Yeah, either do I. You're not alone. Do you think that we can help solve this problem by opening up our schools come September?
I think that's very important. And I mean, we would argue actually at FreeOp, and we've put out some work on this and we're going to put out more. We would argue that actually the school year should start earlier than September to make up for lost time. It's essential for low-income parents and families to be able to get their kids back in school, because the disparities in educational outcomes, let alone economic and public health outcomes that come from poor educational attainment, are incredibly important. And the good news is children are not vectors of infection. At least we have a lot of evidence that they are not very infectious. We don't understand exactly why. They're theories. But there is good reason to believe that reopening schools is the safest thing we can do among all the reopening tools we have.
That's why liability coverage that the schools talk about is essential for their opening.
Yes, and for all employers, I think liability coverage protection, that's the most important thing Congress can do. A lot of reopening decisions are at the state and local level, but Congress can take action on liability protection.
I agree. Thank you, Chairman. I yield back.
Gentleman yields back. I now recognize the gentleman from Michigan, Mr. Kildee, for 5 minutes.
Well, first of all, thank you, Chairman Yarmuth, for hosting this very important hearing. As you know, I'm from Flint, Michigan. The residents of my hometown are dealing with back-to-back crises, the ongoing water crisis, and now the coronavirus pandemic. Both of these crises have disproportionately impacted people of color. Michigan currently ranks 9th among the states with the most coronavirus cases in the country. Genesee County, where my hometown of Flint is located, where I am right now, has had 258 COVID-19 fatalities. In Genesee County, African Americans account for 47% of the fatalities, despite making up 20% of the county's population. This kind of disparity is heartbreaking. We're also experiencing the loss of social interactions, those interactions that help us cope with during times of stress, Also seeing record levels of unemployment, causing many to wonder how they will pay their own bills, maintain access to health care, and feed their families. And on top of this, of course, people in Flint don't have access to water that they trust or that's affordable, many having to leave home just to get bottled water. Because of these compounding stressors and traumas, I am concerned that there may be an additional crisis on the horizon, a mental health crisis that disproportionately impacts our already hard-hit communities. The House passed HEROES Act, which contained policies to help address inequities like creating an ACA special enrollment period for uninsured Americans, and also increased federal Medicaid payments, and $3 billion to support mental health during this challenging time. That was what was included in the HEROES Act. I've also introduced legislation, again, which was included in the HEROES Act, that would extend unemployment benefits to help millions of Americans who are out of work. With that as a background, Dr. Harris, I wonder if you might comment on why a special enrollment period and increased access to health coverage is so important to address the resulting racial inequalities, particularly mental health impacts of COVID-19, and what other healthcare policies are important for Congress to consider as we go forward.
Well, thank you. And I'll make a couple of quick points, but we know that people without health insurance live sicker and die younger. We also know that Medicaid expansion and the expansion through the Affordable Care Act marketplace has allowed so many individuals who would not have been able to access mental health services to do so. And certainly it is important to have this coverage so that you can get this coverage. You also mentioned issues around the water in Flint, and we know that environmental toxins are another determinant of health. And we have to make sure that we look at those issues. And I want to make one more point about language that we use. And one of the reasons that we use inequities is because we want to talk about avoidable differences, those differences that can be prevented. And of course, we've mentioned those structural determinants of health as well that have driven us to the social determinants of this ill health. So, and I remember as a child psychiatrist in training, we used to always check for lead because so many, I trained in Atlanta at Emory, large African-American population, and so many children have been exposed to lead. This was several years ago, but because of where they lived. And so all of these issues are critical if we are to address these health inequities, and clearly the ability to have insurance is one. You mentioned expanding the enrollment period for Medicaid, special open enrollments, Affordable Care Act. We could also help folks retain their COBRA benefits. We could also support employers to offer temporary subsidies to preserve their health benefits. So those are just a few solutions that we would offer.
I really appreciate your comments. My initial career was in the child welfare system, working with children who'd been traumatized. And I have a particular concern, particularly for the kids of Flint who are experiencing a trauma on top of a trauma, not to mention the daily trauma that they see because of their conditions. So I really appreciate the perspective that you bring to this conversation. And thank you so much to all of you for your testimony. With that, Mr. Chairman, I yield back.
Gentleman yields back. I now recognize the gentleman from Texas, Mr. Crenshaw, for 5 minutes.
Thank you, Mr. Chairman. Thank you for holding this hearing. I'll of course say again, we'll state the obvious, and it's been said many times throughout this hearing, that economic lockdowns, in essence, choosing the costliest, most extreme possible option before we went through a series of other options to mitigate the spread of the virus and save our hospital system, that overwhelmingly hurt working class people. And while a bunch of city dwelling, teleworking, I'm sure very nice people advocated for safety and saving lives and continuing to lock down the economy, because God forbid anybody chooses themselves to go out to a restaurant or chooses themselves to go to work, God forbid. That hurt the people that we're talking about today, overwhelmingly. And yes, they're hurt by COVID-19 as well, disproportionately, as all the data points to. Of course, the data, it doesn't even come close to our elderly population. And I hope we do have a hearing about that too, and question why governors such as the governor of New York would actually implement policy which harmed the elderly population the most by forcing infected patients back into nursing homes. That's been conveniently ignored. Because we should always be looking for specific policies that actually help the disparity that we're talking about, things we can actually affect. And I've heard a lot of talking out of both sides of the mouth in much of this. So on the one hand, the economic devastation of lockdowns harms minorities and communities. It does. I just interviewed a black business owner here, and their main problem right now is that they can't get their workers to come back. Why? Well, because their workers are getting paid more on unemployment than they were back at work. I can't get a single Democrat to co-sponsor a bill that would do a simple fix for that. Not take away benefits, actually let them keep the bonus while the program is still going, keep that $600 a week bonus, even if you come back to work. Seems like a win-win. I can't get a single Democrat on it. I don't know why. Because I don't think there's any actual desire to solve problems here, and that's really frustrating. We actually care about really helping people want to help. Mr. Roy, is there any data comparing minority incomes between states that are still in lockdown or came out of lockdown later and those that came out of lockdown earlier?
Mr. Crenshaw, there's preliminary information on that score. What we do see is that, for example, I was citing in my written testimony the stuff around how minimum wage or hourly wage jobs have been cut significantly. There's significant state variation in the states that have reopened. Hourly wage jobs are coming back at much higher rates, and in states that have continued to lock down, the New Yorks, the Virginias, the hourly wage reduction in employment and in hours and wages is massively lower.
So I've heard over and over again that the only solution, that we could possibly have to solving the disparities in health outcomes with something like COVID-19 is a single payer healthcare system. It's got to be the only solution, right? But do countries with a single payer healthcare system, such as England, have health outcome inequalities as well? I've heard they're almost exactly the same as here.
Well, it's interesting that you mentioned this, Mr. Crenshaw, because just today at FreeOp, we published a ranking of the 31 wealthiest countries in the world on the basis of their pandemic response, mortality per million residents, the economic stringency of their lockdowns, and the relative isolation of their economies relative to other countries. And what we found is, just as you said, there are some countries with single-payer healthcare that did well. Taiwan has single-payer healthcare. They come out #1 in our ranking. But Italy comes in second to last, if I recall correctly, and they also have single-payer healthcare. The UK has single-payer healthcare. Their mortality is far higher per million residents in the United States.
And it's also far higher for minorities, too.
Oh, yes, that's true.
Same disparities that we do, and yet they have single-payer. We just have to point these out these facts. If we're going to just jump to a single solution, we have to at least agree on a common set of facts. Also, what are the public health impacts of lockdowns, especially with low-income and minority communities? Aside from economic and job loss, what about public health?
This is a really important question, and I mentioned it a bit earlier in one of my other responses. A lot of this is going to be difficult to measure because we don't actually. Some of these effects are going to be long term. The person with chronic disease that didn't have it managed over this period of time, the manifestations.
That's what we're seeing in Houston, by the way. The uptick in cases is that's not their lungs being inflamed. I realize I'm out of time and sorry to interrupt you, but thank you, Mr. Chairman, and I yield back.
Gentleman yields back. I now recognize the gentleman from California, Mr. Panetta, for 5 minutes.
Thank you, Mr. Chairman, Mr. Womack, and appreciate both of you holding today's hearing on the inequalities and dealing with COVID-19 pandemic. And of course, thank you for the witnesses for all of their expertise, all of their preparation and their time for coming to talk about hopefully not just the problems, but some solutions that we can have going forward in this pandemic and addressing the inequalities in our nation. As many of you know, over the last 3 months, what has been highlighted are those inequalities from healthcare to wealth, to education, to justice, and yes, to housing as well. and they've collided clearly with one of the deadliest pandemics the world has faced in a century or more. But unfortunately, what we're seeing is that the lower income, and yes, the communities of color, have borne the brunt of this pandemic. And we see it right here in where I represent, where I live, where I grew up, on the Central Coast of California. As my friend, Mr. Kildee, likes me to say, here in the salad bowl of the world, obviously we have a lot of agriculture, but we have a unique sort of agriculture that doesn't take machines, it takes human beings to harvest. And so we have thankfully, a large immigrant community that has contributed so much to our economy, to our community, and to our culture, who we are. In Monterey County alone, look, I'll be the first to admit, we're not a hotbed at this point. We only have as of yesterday, about just over 1,200 cases of COVID-19, and we've endured 12 deaths, unfortunately, because of the disease. But within that number, 80% of the COVID-19 cases have been found in the Latinx community, and nearly 40% have been farm workers. And so unlike some parts on the Central Coast, this community has not had the option to work from home, as you know. It's our farm workers that continue to work through this pandemic, put food on all of our tables across this country, not just here on the Central Coast, and yes, provide this country with the food security that is so needed, especially at this time. And even now, as cases spike up in California. And so, Dr. Harris, I want to address questions to you, if that's all right. As you probably know, 25% of undocumented farm workers in the United States have health insurance. It's only 25% of undocumented farm workers, which unfortunately, I think we know there are a significant number of undocumented farm workers. What do you feel are the ways that we can ensure that farm workers get the health care that they need despite the obstacle of uninsurance? And are there changes, solutions, like I said, that Congress can put forward to help undocumented immigrants gain access to healthcare providers? Dr. Harris. Your microphone. The word of this.
Yes. Thank you. Certainly leave it up to the wisdom of this body and your colleagues in the Senate to the how. But I can tell you that it is important for everyone to have access to insurance because just like this virus that may have impacted first others in other countries, we say the pandemic or an epidemic anywhere certainly impacts us here in the U.S. And so illnesses don't respect state boundaries, county boundaries. They don't know who is here and who is documented, who does not have proper documentation. And so it is really important. The AMA made a strong statement about making sure that children had access to vaccinations and quality care from their pediatrician. And so I will just say it is important for everyone to have access to appropriate health care.
Understood. Now, obviously, we've heard from a couple of my colleagues, and I'm seeing it here on the Central Coast, telemedicine has been helping. Yet there are some difficulties, obviously, with foreign-born or non-English speaking population. Dr. Harris, are there ways that we can improve that for rural areas and communities of color?
Absolutely. Telemedicine, certainly, and many of us, I know I used telemedicine pre-COVID, but certainly COVID did accelerate that use, and we appreciate the relaxation of the regulations, but we need to look at issues around broadband. Actually, in both urban areas and rural areas, we need to look at the issue of whether or not there is a computer or more than one computer, and confidentiality, we are talking about private medical needs. So these are all needs that need to be addressed as we move forward with telemedicine.
Thank you, Dr. Harris. Thank you again, Mr. Chairman. Appreciate the opportunity. I yield back.
Gentleman yields back. I now recognize the gentleman from Tennessee, Mr. Merchant, for 5 minutes.
Thank you, Mr. Chairman, and thank y'all for being here, Mr. Ranking Member. I could take a personal privilege. I hope we all remember our colleague Andy Barr in our prayers, lost his wife, and 2 beautiful little girls lost their mama, and that's just, me, it's just heartbreaking. My wife was a widow, and I married her and adopted a little girl, so I know, and she's talked to me about the impact of that, so I hope we all remember Andy in our prayers. I appreciate the opportunity to be here. And Ms. Harris, I would ask if you, when you started talking about telemedicine, I was up in Claiborne County, and I'm sure you know what Claiborne County is. Nobody does. It's a very small county. It's about 2% of my district, but they actually utilize telemedicine. And I would encourage you all to reach out to them and some of the folks up there, because they had some great success with that up there, especially during this the outbreak of the virus. For Mr. Roy, I was wanting to know, you've studied and published some of the failures of Medicaid to improve our care for low-income Americans. How can we leverage some of that to treat and contain and prevent the spread of the coronavirus? And how will this solution actually provide better care to some of our more vulnerable population?
Well, let me go back to something Mr. Crenshaw just was pointing out, which is that the biggest disparity, the single biggest disparity when it comes to the impact of...
Can I stop you? Can I stop you 1 second? Don't ever refer to Dan Crenshaw, because his ego is so big. I don't know if his head's going to fit on the screen much more, but please continue.
Fair enough. I respect that, Mr. Burchett, so apologies. The biggest disparity is the fact that 0.6% of the U.S. population lives in long-term care facilities, nursing homes, and assisted living facilities, and that's where 43% of all U.S. COVID-19 deaths are occurring, and 81% of all deaths from COVID-19 are happening among people aged 65 or older. And how does this relate to your question? It's because Medicaid is one of the biggest drivers of this problem. Because if you are medically vulnerable and you need help with activities of daily living, and you're in Medicaid, you have to go to a nursing home to get the care you need. You're not allowed to use Medicaid dollars to get that care in your own home. That's one of the things about Medicaid that's incredibly inflexible. And that's led to an enormous distortion in the way we deliver nursing home care. And it's also put the Medicaid population in disproportionately harm's way.
Well, let me ask you also, I know you've done some research on the economy prior to the coronavirus. What would you suggest that we could do between state, federal, and local elected offices and I guess just the bureaucracy to make this thing work out better and provide better health care for our country?
Well, I think the most important thing we can do, and as you may know, we have a plan that we put out at FreeOp called Medicare Advantage for All. And the basic idea is that everyone should own their own health insurance, and they should be able to take it from job to job. And the way you do that is by reforming the market for people who buy insurance on their own, the one that Obamacare made so much more expensive, and improve that market so people really have choices.
Gentleman from California, from New York, Mr. Morelli, 5 minutes.
Thank you, Mr. Chairman, very much, and thank you once again for holding a series of important hearings to talk about the pandemic and the impact that it's had. I do just want to state for the record that if the President of the United States had demonstrated half the leadership of my friend, the Governor of New York, thousands of Americans might not have contracted COVID-19 in the first place. But I'll leave that to another date. But I do want to defend my friend from New York. I do want to talk about, obviously, the wealth and health inequality in America, and the devastation that's occurred in the wake of this crisis has made all the worse by the deep-seated inequalities that have plagued our country for decades. Racial and wealth disparity were at the root of our nation's academic achievement gaps before COVID-19. I don't have to tell any of you that we know that health and education are intrinsically linked, and economically marginalized and segregated neighborhoods are more likely to have less access to resources that help children and adults lead healthier, safer lives. And the resulting and persistent cycle of systemic disadvantage, whether it's academic achievement gaps, healthcare disparities, and unjust wage differences for Black Americans compared to their white peers, has made it near impossible to gain equity in this country. The pandemic has not only shined a glaring spotlight on the lack of investment and resources available to Black communities and schools, it's exacerbated the health and educational gaps to a breaking point. So as we begin to rebuild our communities and regain our footing, we have a very real opportunity and a responsibility to take intentional and preemptive actions to safeguard these communities against further fallout and to address the underlying social determinants of health that we've seen reflected in other diseases for decades. And deep-seated inequalities have plagued our community. In my community, we have seen a 4 times rate of infection, over a 5 times rate of hospitalization, and a 2.5 time mortality rate among Black Americans in the Rochester, New York community. So I know that we are not alone. That's being experienced around the country. I want to ask Dr. Harris, how has the COVID pandemic worsened pre-existing racial inequities in neighborhood quality and in the built environment, as well as access to community health support services for people of color?
I think three overarching areas, and thank you for the opportunity to answer the question. I think, first of all, again, the pre-existing conditions, again, that were already there before COVID-19, the disproportionate impact of diabetes, hypertension, asthma, obesity. Secondly was you had more members from communities of color who were working those essential jobs. It's been noted they didn't have the privilege of staying at home. They had to go out and work. Actually, so many of us who had the privilege could have the food security. And of course, that increased their risk of exposure. And third, I think it's the misinformation, the disinformation that has been out there. And then we really have to talk about 401 years of racism and discrimination and bias that have led us. We here in Atlanta is working with the group, and we were looking at the discriminatory housing policy of redlining, and we could line up those neighborhoods with the zip codes now that we see with severe health inequities. I do want to say something. I do respect Dr. Roy and, of course, respect a marketplace of ideas. I do want us to have a closer look to the rising tide lifts all boats. That is true, but that's not sufficient. I think we need to dig deeper because it may lift all boats, but it may not lift everyone up. It may not lift every boat up to where it needs. Everyone can get an equitable opportunity for health. So I think as we think about that, we have to at least I would worry about these one-size-fits-all solutions.
Thank you. I want to ask Dr. Deaton and any of the other panelists might comment as well, but how can we, as we begin to move forward, rebuild our economies and our communities in a purposeful way that prevents the further deepening of the academic achievement gap, particularly as we head into the summer months? Do you have any thoughts on that, sir?
Sorry, I didn't hear a question. Was that directed?
Yeah, I just want to know as we sort of, and I may be running out of time, so I just want to, any thoughts you had on rebuilding our economy communities in a purposeful way to prevent the further deepening of the academic achievement gap, particularly as we head into the summer months when many students are not in school?
Yeah, I think that's going to be one of the hardest problems that we're going to have to deal with, especially as the lockdown of schools, which was probably not a very good idea, has widened these gaps enormously. So I'm very much with that.
I yield back my time. Thank you, Mr. Chair.
The gentleman yields back. I now recognize the gentleman from Texas, Mr. Flores, for 5 minutes.
Thank you, Mr. Chairman. I appreciate the opportunity to participate in today's hearing. And my broadband service has been a little bit spotty today, so I'm hopeful that everybody can hear me and that I don't drop off in the middle of this, in my middle of my 5 minutes. Mr. Roy, in previous testimony, you said, quote, "The association is clear. A strong economy most benefits minorities, and a worsening economy most hurts them," unquote. House Democrats have made known their desire for heavy top-down structural changes in our economy. And so my question is this: in your view, is this top-down heavy-handed approach the best policy direction for helping minorities, or would you recommend policies more focused on strengthening the economy, thus providing greater opportunities for minorities?
Well, leaving aside the party piece of it, I mean, I would just say definitely that economic growth is incredibly important, and we have to be extremely mindful of policies that would not only suppress economic growth, but suppress job growth. You know, we've talked a little bit today about the $600 bonus that's leading people to basically not get back into the workforce, and that's retarding the economic recovery. So I'm very concerned that I hear the Congress is thinking about renewing or restoring or extending that policy. That's going to make it a lot harder for employers to get back on their feet. And we're going to see, we already have seen 100,000 or more small businesses close because of lockdowns. That number could increase considerably if that feature of the CARES Act is extended.
One of the related features that's come out of the pandemic, and not only in terms of economic impact, but it has a follow-on economic impact, is the fact that we have several regulations that were found to to impede our ability to respond to the pandemic. Things like hand sanitizer guidelines, truck driving limits, things like this. So I have a question for all of the panelists, starting with Dr. Deaton. Are there any regulations that you think of that have hindered the ability to respond to challenges of the pandemic? And are there any regulations you can think of that disproportionately harm minorities and low-income communities?
Well, I'm someone who feels that one of the greatest disasters in America these days is the healthcare system. And much of that is to do with regulation. I have a different view, though, that I think removing the regulations is not the right way to go. I think that what we need is a system that automatically insures everyone from birth. I think we have to have a system that controls costs, which is very important. It's true that our healthcare system has not done any worse in this pandemic than other countries' healthcare systems, and it's too much really to ask any healthcare system to deal well with something that only happens 100 years ago before. But
I have just a few minutes. Dr. Deaton.
Sorry?
Excuse me, can I go to Dr. Harris? How about the regulations question?
Well, I think we chatted earlier about the regulations regarding telehealth and think that was very important. And I will say this from a broader perspective regarding substance use disorder, not necessarily just communities of color. It was important to reduce a lot of those regulations so that patients who had an opioid use disorder could get the medications that they needed. And we didn't have the dose limit or the time limit. So those were very helpful as well. And there was some loosening of regulations regarding prior authorizations for services and medications, and those were helpful as well during this time.
Okay, thank you. Dr. Jones, can you give me 30 seconds in terms of regulations that have hindered the ability to respond to the pandemic and regulations that disproportionately harm minority communities? Mr. Roy, we'll get to you when we've got about 30 seconds left.
At the moment, there are no specific regulations that are coming to mind for me, so I will pass it on.
Okay, Mr. Roy.
Well, I'd love, Mr. Flores, for Congress to make permanent some of the regulatory relief that's been temporary around telemedicine, telehealth, practicing medicine across state lines, allowing your license to be used if you've moved states without having to get recertified. Those are some of the simple things we can do, not just for physicians, but also for nurses.
Right.
Broadly speaking, I should mention that the regulatory reforms of the last several years are a big driver of the record low unemployment that we enjoyed prior to the pandemic. That's worth noting as well.
Right. I appreciate it, and I agree with you. I think the regulations that we've modified in light of this pandemic should be extended permanently. I yield back, Mr. Chairman.
Back, I now recognize the gentleman from Nevada, Mr. Horsford, for 5 minutes.
Thank you, Mr. Chairman, and to the ranking member for holding this hearing, and to all of our panelists for joining us today. Dr. Harris, it's great to see you again. Thank you for your tremendous leadership over the years at the American Medical Association and in your practice. As many of you may be aware, Nevada, my home state, is the hardest hit state economically in our nation and has the worst unemployment rate at over 25.2%. as a result of the coronavirus pandemic. Few places were hit harder than Las Vegas, where a full 1/3 of the Las Vegas economy is in the leisure and hospitality industry, more than any other major metropolitan area in the country. Most of those jobs cannot be done from home. The New York Times did an article back in April that was titled "How Las Vegas Became Ground Zero for the American Jobs Crisis." And they brought to light the devastating impacts that this virus has on African-American families and those Latinx and other communities throughout Southern Nevada. The article highlighted how Mr. and Mrs. Anderson both lost their jobs at a restaurant and a call center respectfully, and immediately began to worry about how they would pay rent and provide food for their daughter. This is one of the many examples as to how COVID-19 has dramatically impacted African-American households. In 2018, the poverty rate for African-American families was more than 2.5 times the poverty rate for whites. and the poverty rate for Latinx families was more than twice that of whites. Disparities in the child poverty rate are even more stark. The child poverty rate for African Americans in 2018 was more than 3 times the child poverty rate for whites, up from about 2.5 times the rate for whites in 2013. But none of this is a coincidence. The inequities we see today were not caused by COVID-19. They are a result of systemic racism that has impacted every aspect from health to education, financial, housing, and other institutions, and it has affected the opportunities across the board. Now, there's data that I just read yesterday from the Center on Poverty and Social Policy that indicates how the child poverty rate could be cut in half if Congress would approve the American Family Act, which expands the child tax credit that would provide $3,600 for kids under 6 years of age and $3,000 for older kids. That poverty rate among Black children would drop by 52% and among Latinx children by 41%. Dr. Harris, what long-term effects might the COVID-19 pandemic have on children, and how might it affect their physical and mental health, as well as their economic potential in the long term?
Well, certainly many areas there, but let me just highlight one or two. And the first is the issue around trauma. We have burgeoning evidence that trauma experienced early in childhood, many may be familiar with the Adverse Childhood Experience Survey, leads to both short-term and long-term health impacts, and not just mental health, not just psychological health, but also long-term cardiovascular health, diabetes, some of these other issues. We certainly think about abuse and violence as typical trauma, but certainly the day-to-day traumatic experience of racism and perhaps living in poverty and some of these other issues can also have a cumulative effect. It's known in some papers as weathering effect on African Americans. And so again, and earlier I talked about previous housing discriminatory housing policy. So all of these impact both short and long-term health.
Thank you. Dr. Jones, briefly, how does structural racism affect health outcomes in the United States, and how does it affect the quality of care that people of color receive? Some of the health behaviors relating to housing and food availability and other social determinants.
Yeah, I think that there are a number of ways in which structural racism can affect these health outcomes. I think that when we look at the United States and compare to other countries in terms of health outcomes, we have relatively high rates of maternal mortality, for example, during childbirth. And some of this could be linked to discrimination or biases among doctors and how they view, for example, Black women. And so these deep-seated issues of racism, they are prevalent when doctors are being trained. It feeds into the composition of doctors that we have, and then it can spill over into the types of services that are delivered. That's just one example.
Thank you very much, and I yield back.
Yields back. I now recognize the gentlelady from Texas, Ms. Jackson Lee, for 5 minutes.
Thank you very much, Mr. Chairman. I'm in the office with 1 or 2 staff. I'll take off my mask. It is obviously in Texas, we have been hitting a spike of enormous proportion. Our hospital beds are now overwhelmed. Our emergency rooms are overwhelmed with COVID-19. And I think this is certainly an appropriate hearing as it deals with wealth inequality in America. And really, as I've been listening, the lack of access to health care. So I'm going to, if I might, Dr. Harris, if I might focus on you. And my focus will hopefully be an area that you have had some exposure to just by hearing the word, but I'm going to articulate it in a more definitive manner. And I'd really like, first of all, let me congratulate you, Dr. Harris, for your leadership of the American Medical Association and really the innovative work that you have been doing as relates to healthcare disparities. It is very distinguished and well appreciated. So I would like to as well comment on this inequity and wealth. I heard someone attacking the Affordable Care Act. If all of the states, the red states, had accepted the Medicare expansion, we would have included more persons. If we had allowed the Affordable Care Act to take its will and to be able to develop the body politic and to include young people, we would have had a very strong healthcare system. But it's been attacked and stripped and strained, and it is an outrage. I do believe that Medicare should be modified to include the opportunities for individuals to be in their homes and still have the ability to have care as persons who are in need of care. But my question to you is that we have experienced over the last couple of weeks the recognition by many of systemic racism. We've introduced a legislation for over 30 years called the Commission to develop proposals for reparations and proposals. It is a thoughtful, articulate expression of addressing the question of systemic racism and presenting a commission that will look at the issues of healthcare, the economy, psychological issues, sociological issues, scientific issues. And I think we have a vehicle that can address what we're trying to do piecemeal, meaning that we have people focus on the over 200 years of slavery that have obviously had an impact in the denial of wealth, the inability to transfer wealth. So you're a doctor. I'd appreciate your commentary on looking at it through the eyes of a commission to deal with and develop real proposals on the question of the plight of African Americans as relates to any number of issues, and you may speak to the issue of access to health care. I believe another witness is Dr. Jones from the University of Chicago, but Dr. Harris, could you please answer the question?
Issues that you mentioned and that might be addressed in that legislation are critically important issues. For many years, I think we looked at health through a narrow lens, and now we really have to open up that lens. And when we are talking about these health inequities, we do have to go back to the 400 years of slavery and Jim Crow and all of those issues. I will say something that the AMA has done regarding reconciliation. Many of the audience and many of the members of Congress may know that for decades, the AMA did not allow Black physicians to belong to the AMA. And we do believe that probably impacted where we are today. So we are looking internally as we move forward. But in 2008, the AMA went on record to apologize for that. Now, that was a necessary step, not sufficient, and we have done things since then. We have a new Center for Health Equity, but critically, an important note in reconciliation is admitting your past mistakes.
So you understand reparations is repair, and it's different from reconciliation. So I'm talking about
I do.
HR 40. And do you believe we need reparations, repair, and restoration as well?
Well, I have to say, I'm here representing the AMA today. I don't think we have taken an official position, but I am a Black woman in this country, and I do think we need to look at that issue seriously, and particularly how those issues impacted health.
Thank you. Is Dr. Jones there? Dr. Damon Jones? Thank you very much, Madam President. Hello?
Yes.
Thank you.
Yes.
Could you respond to that as well?
Yes, so I think that, as I mentioned, I think that we should move forward with that bill to create a committee. One of the steps has to do with reconciliation and gaining closure, but as you mentioned, there's also redress for what has happened in the past, and so material reparations, I think, as well should be included. Both of those are important because we continually see ourselves back at the same point with racial strife in this country. And so we're not going to get past that without looking deeply into this country's history and trying to repair some of those harms.
I commend HR 40 to both of you in terms of looking at it from your perspective on healthcare. The commission appointed by members of the United States Congress leadership and the President of the United States would then be tasked with developing a repairing and restoring of the seismic impact of slavery, the original sin, on African Americans who don't have the inherited wealth, who are impacted by health disparities in a very severe manner and are impacted more severely by COVID-19, both economically and health-wise. We need a systemic change dealing with systemic racism. And I think as we look at it from the budget perspective, all of our committees could look at this extensively. And I'm just going to you, Dr. Jones. I know I have a second or two, but we have to look at it holistically, and repetition is a way to do so. Dr. Jones?
No, you're way over time. You're way over
All right,
time.
well,
I'm sorry. Gentleman's time has expired.
Thank you. All right, thank you.
I now yield 5 minutes to the gentleman from Virginia, Mr. Scott.
Thank you, Mr. Chairman. Mr. Roy, let me ask Mr. Roy a question first, and I thank you for testifying in the Education and Labor Committee yesterday. When you say liability protection on coming back when reopening, are you talking about liability insurance coverage so that victims can get covered, or are you talking immunity where the victim is stuck with his own bills?
Well, I don't know if I'm exactly talking either of those things. What I'm talking about is employers are very reluctant to reopen their workplaces because they're concerned that if a single worker at their place of employment eventually gets COVID-19 and that COVID-19 was contracted somewhere else but outside of the workplace.
But who, if people get sick and the employer could pay under present law?
Oh, well, that's different, right? So if the employer is paying for their health insurance, then the health insurance should cover COVID-19, of course.
Okay, so when you talk about liability protection, are you talking about insurance company to cover the liability, or are you talking about immunity where the employer is home free?
Well, I'm talking about legal protection for employers so that they are not at risk of bankruptcy due to someone who contracts COVID-19 outside of the workplace.
You could do that with insurance.
You could do that through, but the employer pays for the insurance, right? So if the employer pays for the insurance, that increases the cost of employment.
Okay, well, I don't think you had an answer to that. Let me ask Dr. Harris a question. We've heard a lot of disparaging remarks about the Affordable Care Act. Dr. Harris, you are aware that when the Republicans tried to replace the Affordable Care Act, their replacement was scored by the CBO, and it concluded that the cost would go up 20% the first year, 20-some million fewer people would have insurance. Those with pre-existing conditions would lose their insurance, and the insurance you get is worse than what you got. Can you say, so we know that ACA repeal and replace, but repeal just generally, and Medicaid expansion, could you just say how Medicaid expansion would be helpful to reduce the disparities, and how ACA repeal would be harmful and make the disparities worse? Dr. Harris?
Can you hear me? Thank you.
Yeah, I can hear you now.
Thank you. Yes. And as you know, the American Medical Association did support the Affordable Care Act. Certainly, it was not a perfect piece of legislation, but it did move us further in reducing the number of uninsured in this country. And at this point, we believe that the best path forward is to strengthen and enhance the Affordable Care Act, and that does include the expansion of Medicaid. Certainly, I know so many, and I am a psychiatrist, but in all disciplines of medicine, so many previously uninsured patients were able to gain access to health care through the Affordable Care Act. And we also know that if you don't have insurance, and of course for many other reasons, lack of access, all of the social determinants of health, you live sicker and die younger. And so we at the AMA continue to support strengthening and enhancing the Affordable Care Act. We continue to support bipartisan and bicameral solution to getting us to a point where everyone has affordable, meaningful coverage in this country.
Thank you. And I'll ask our other witnesses, we can talk about the problem or we can come up with solutions. We're talking about a lot of solutions about income and wealth inequality. Some of the things we're working on or increasing the minimum wage, making it easier to form a union so you can negotiate for higher wages, investments in education, particularly higher education, and making that affordable, housing, home ownership initiatives, because that's where most middle class families get their wealth, and fighting discrimination, everything from employment to business loans to housing, so that equally postured people will get, the minorities will not be worse off. Can you say anything about which of those initiatives are most important, or anything else that we ought to be actually working on?
This is Angus Deaton here. Yeah, I mean, I think I've made a case for all of these in some of my writings. The one I would emphasize that you didn't emphasize is I think we have to somehow rein in the cost of healthcare. The cost of entitlements, as we've heard, are bankrupting the nation. But the cost of entitlements are so large because healthcare costs so much, and we've got to bring those costs down. The waste in healthcare is 50% more than we spend on national defense. And that is just a completely crazy number. And other countries manage to do this, not necessarily any better than we do it, but they do it at less than half the cost. And that would stop the bleeding of employment for less skilled Americans, for African Americans, and it would give us a chance to get back on a reasonable chance of prosperity for less fortunate Americans who've really been suffering over the past 50 years. It's okay to say the economy was doing pretty well up until February, but people were dying in droves, and there were 158,000 deaths of despair last year. That's not something that happens in a well-functioning economy. Thank you.
Thank you.
Time has expired. I now recognize the ranking member. Oh, sure. I now recognize the ranking member, Mr. Womack, for 10 minutes.
Thank you, Mr. Chairman, and thanks to all of our panelists today. Let me begin with part of my thesis when I opened in my opening remarks in talking about deficits and debt and the need for certainty, the need for, I didn't talk necessarily about budget reform, but the chairman and I have a long history on promoting some kind of reform so that we can get to the business of doing the people's work without CRs, omnibus packages, and those kinds of things. I just kind of put all that in the category of bringing certainty to the governmental process. But in my thesis, I talk about the pressure that deficit and debt, and in particular, the net interest on the debt, which is rising exponentially, and the impact it's going to have on programs that benefit largely the vulnerable population. And whether it's in the minority communities or vulnerable seniors or this sort of thing. So here's my question for each of the four panelists, and be very brief in your response because I don't have a lot of time, and I hope not to use all of my time, but we'll start with Mr. Deaton. Does deficit and debt matter? And is it a concern of yours? Because we've had a lot of proposals thrown out in this last couple of hours. All of them have a price tag to them. Do deficits and debt matter? And if so, when should we be serious about it?
I think deficits and debts do matter. They matter in a somewhat complicated way, and it's a very lively topic of discussion among my colleagues. But let me go back to something I said a minute or two ago. Before COVID came, and COVID is a whole special case because we've never had budget deficits, we've never had a pandemic like this before. Before COVID, all the red ink out into the future is driven by the high costs of medical care. If we can bring that under control, then we wouldn't have this problem. So this problem is important, and that's the key to getting it under control.
Dr. Jones.
Yeah, I would say that it is important to think about deficits and debt. I don't think now is the time to place the most weight on that. I think we are in an emergency situation. We're in a crisis. And that is the time where you draw into the deep pockets of the federal government to bail people out. because there are people in deep need and they're in need of relief. I think that if interest rates were rising, or if we thought that there was not enough capital flowing around for people to borrow, then you may think more about these things, but I don't think that that's the case.
Dr. Harris.
I don't feel qualified to talk about deficits and debt, but I do want you to know that as physicians in the physician community, we do think that we need to continue to have fair-minded debates around the cost of healthcare, the value of healthcare, and healthcare financing. So I can commit that we'll be a part of that conversation, and I'll leave it to the economists for the deficits and the debt.
Okay, so Dr. Roy, as you get ready to answer the question, and I'm paging through some of your testimony, but you said early on, if I can, and I may not be able to find it, but you said you made a case early on in your testimony, in your opening remarks, about the impact of deficits and debt and the pressure it's going to have on all of the programs, particularly the social safety net programs, but in addition to a lot of other programs that affect specific communities that we're talking about here today. So I'm assuming that you believe that deficits and debt do matter.
Absolutely. I completely agree with what you were describing earlier about how a fiscal reckoning will particularly harm economically vulnerable populations, and I do describe that in my testimony. One thing I should mention is that we've actually put out a comprehensive plan called Medicare Advantage for All that involves universal private insurance like that in Medicare Advantage for everyone. And there's actually a bill that's been introduced in Congress by one of your colleagues from Arkansas, Bruce Westerman, that's based on that bill. And one thing I should mention that we talk about extensively in that report is how to reduce the high cost of U.S. healthcare. One thing I should mention in this hearing in particular is the fact that the way in which Medicare pays physicians for their care and the prices that Medicare pays for that care are determined by physicians. There's a secret committee of specialty societies called the RUC committee that basically determines what prices the taxpayer pay through Medicare for those services. It's one of the most egregious examples of conflict of interest in the federal budget, and it's something that I hope Congress can revisit as it tries to find ways to reduce the high cost of healthcare.
Well, and back to your testimony, I subscribe to the notion that deficits and debt do matter because eventually we're going to become a credit risk. And when you become a credit risk, you're going to be paying more in interest for the people that are buying your paper. And if that's the case, then the more interest you pay, and let's face it, I don't know what the deficit or the debt is today. I know the deficit we're going to rack up is somewhere in the vicinity of $4 trillion. But the net interest on the debt that we're going to pay for, and I'm an appropriator too, so I can speak to this, is going to put a lot more pressure on our ability to fund a lot of the things that most of the panelists, all of the panelists, my colleagues on this panel, believe are important to our country on the discretionary side. It's going to put an enormous amount of pressure on that. We're going to pay more in net interest, and I believe that eventually net interest on the debt is probably going to exceed what we spend on national security, which would be unheard of in my opinion. So I subscribe to the notion that deficits and debt do matter, and we got to be careful when throwing around a whole lot of other programs that are going to cost an extraordinarily amount of money, not necessarily intent on raising the revenue that would need to go to support it. I said in my opening statement that before COVID, this country was clicking along at a pretty good pace, and specifically to our minority communities, Black, Hispanic, Asian unemployment, 5.4, 3.9, 2.1% respectively. Now they've gone higher because of COVID. It makes sense to me, Dr. Roy, that when we climb out of this COVID hole, that we need to go back to the policies that had us on track and had historic lows of unemployment and economic prosperity before COVID hit. Would you agree?
Well, there's no doubt that the quicker we can get back to that policy mix, that would be great. I'm very concerned that we won't, and I'm very concerned that Congress is on the verge of making it worse. Because if Congress gives states a powerful incentive to stay locked down, then that is going to continue to retard the recovery, retard the ability of those lower income, economically vulnerable populations to get back to work.
In my remaining time, one of the things that an emergency like COVID forces a country to do is to become
less dependent on the way we've always done things and start looking for innovative ways. And so in the area of particularly of healthcare and education, we've had to rely a lot more on what we're all doing on computers, kind of like what we're doing here today. And so I would assume I would get an affirmative response from every single one of you that in a future infrastructure package, the ability for this country to get rural broadband, and maybe I shouldn't just say rural broadband. I think one of you said earlier, even on the inner city, we have some connectivity issues. But this country does have the capacity to become very innovative in the way we teach, in the way we do research, and in the way we do particularly telemedicine using these devices that we're all on here today. Do you agree with that, Dr. Deaton?
Yes, I do. I mean, I'm not sure we would agree on all the details, but for sure, fast internet access for everybody is incredibly important, and then we can let us grow from there. And
Dr. Jones, would you not agree that one of the things that we could be doing to boost the opportunities for everybody, but particularly the minority community, is get Chromebooks or iPads or the connective devices attached to the World Wide Web for the express purpose of helping educate and better treat people with underlying medical conditions. Would you not agree that broadband is important?
I would agree that it's important, especially now when we need to be socially distant and we need to replace our usual interactions with internet access. That access is uneven for a number of reasons, and making broadband widely available would be.
Dr. Harris, from the AMA perspective, obviously we've come a long way with telehealth and probably could go a lot further, could we not?
Absolutely, and broadband is critical, and so is innovation.
Dr. Roy?
Agreed.
All right. Chairman Yarmuth, I'm going to yield back. It looks like I'm down to zero. So I have nothing to yield back to my friend from the Commonwealth. Thanks to all of you. Appreciate it. Thank you so much.
I thank the ranking member. Before I get into my questioning, I ask unanimous consent to submit statements from America's Essential Hospitals and the Campaign for Tobacco-Free Kids into the record. Without objection, so ordered. I now yield myself 10 minutes. First of all, let me once again thank all of our panel. Your responses have been very helpful and insightful, and your prepared statements as well. I enjoyed reading all of them, and there was a lot of real good food for thought in all of the statements. One of the things that I've been doing a lot of recently, and I think probably most people who are in this hearing have, is what happens after we get through this current challenge? What happens when we're on a more stable economic footing, and what happens once we can at least control the coronavirus? And it seems to me that there are a couple things that we probably have learned or are learning. And one of those is that there are a lot of jobs in this economy that nobody really gave much thinking to, but now have become pretty important jobs. And I was on a phone call several weeks ago with a group of union members, and Professor Deaton, I really appreciate your discussion of unions in your testimony, the importance of revitalizing unions. But anyway, there was a guy on the phone call named Greg, and I don't know whether Greg was black or white, but Greg is a maintenance worker in one of the public high schools in my district. And it occurred to me that 6 months ago, there was not a person in the country who would have given any thought to Greg. But now, as we start thinking about sending our kids back to school and worrying about their safety, all of a sudden, Greg is a very important person, as are the people who stock the grocery shelves and the people who drive the buses and a lot of people who have never really been valued and compensated as commensurate with the role that they play. And so it occurs to me that one of the things that's going to happen as we get through this, And we know, particularly if there's a Democratic Senate and a Democratic president after this next election, that there's going to be a serious conversation about universal basic income. There's going to be a very serious conversation, as has been mentioned here before, about reparations. There are going to be very serious discussions about Medicare for all or some kind of single payer system. And all of these programs absolutely do come with a cost. On the other hand, as I think we all recognize, and I'm getting to a question for you, Professor Deaton, is that when programs by themselves are not going to end systemic racism, the federal government, no matter what we do, is never going to end that. It's a responsibility of the entire society. Corporate America has a role and so forth. But the idea that the primary way to address the systemic racism and inequities in the country is to create a stronger economy where the ships all rise, seems to me to defy history. We've basically relied on that theory for a long time, and it's not really helped. Could you elaborate? Could you comment on that, Professor?
I'd love to. Thank you very much, Chairman. It's certainly true that growth is good. I mean, we would all like more economic growth and less economic growth. And when growth is high, you can give someone to everyone, something for everybody, and it's much easier to deal with social conflict. I think those days have by and large gone. And while there's been a lot of growth in the American economy over the last 30 years, it's not equally distributed. And I don't really care that much about inequalities. I'm saying a horrible thing here. But what I really care about is the large number of people who are being left behind by this economic growth. And this economic growth is going to the top. It's not going to the bottom, whether you're talking about African Americans or you're talking about less educated whites. And, for a long time, people have saying, well, the numbers aren't really right. People are getting a lot more economic growth than the government is measuring. You should use these measures rather than these other measures. But, that's not really right. And when you see people actually destroying themselves in huge numbers, 158,000 people who destroyed themselves through drug addiction, through suicide. We're the only rich country in the world whose suicide rates are actually rising. Everybody else in the world, and all those people who are killing themselves, who are doing away with themselves, are the less educated Americans. And it's true that their wages were rising up until February. Their unemployment was the lowest rate it had been for a very long time. But they're still worse off than any time they were in the 1980s. And this economy is just not delivering for them. I mean, it may be rising, but it's only raising the boats on the top. And it's very hard for me to see how anyone with a serious straight face can continue to talk about trickle down and how if the economy goes up, everyone goes with it. The factual record is just 100% against that. Thank you.
It seems like we also have a very recent experience with kind of the systemic disadvantages that Blacks face in this country when the PPP program came out in CARES. And one of the first things that we realized and it got off to a rocky start, but that was understandable. We didn't have agencies that were prepared to deal with millions of applications. But one thing we found out was none of this money was going to Black entrepreneurs, Black business owners, very little of it. And partially because they didn't have banking relationships significant enough to get help. They didn't have opportunity to go out and get legal counsel to help them navigate through it. And so we actually set aside some more money in HEROES Act to go specifically to Black and women-owned and minority-owned businesses. But to me, that seems to me one of the big arguments against relying on economy-wide initiatives to actually attack the inequities. Because there are these fundamental disadvantages that many people in the country, largely, and many of them are Black, face in trying to even deal with the systems that we set up that might help them if they had access to them. One of the things I want to talk about briefly, and I hate to get into healthcare debates because you can talk about it forever, but Mr. Roy talked about Medicare for all that was transferable and encouraged mobility. And one of the things that occurs to me is that employer-based insurance, and we are the only country in the world that has that, the only industrialized nation that has employer-based insurance, also exacerbates the disparities because you have so many people in the category in Black America and poor whites and so forth who are working in jobs where there is no coverage through their employer, or they're the first ones that are going to be let go and lose their coverage, or the coverage is so expensive that they get no growth in their wages. So I would love to see Dr. Harris, Dr. Jones, how you think about if you see that as a huge problem, the idea that employer-based insurance has a problem with exacerbating inequities.
Yeah, maybe if I can comment first, I would just say a couple of things on that. I think that right now, as we're going into a recession, we're seeing that there's a huge cost to having your insurance tied with your employer. There are a lot of people who are losing their job, and that's going to create a break in the continuity of their care and their access to health care. I also think that the other thing is that when I talk about the labor market and workers' bargaining power, and a lot of what you're seeing in terms of workers not being covered by health insurance is related to their inability to have collective bargaining and to command better compensation and benefit package from their employers. So in the meantime, I think that increasing the ability for people to collectively bargain is going to allow them to have higher quality jobs and compensation.
Yeah. I appreciate that. I apologize. I attributed the union comments to Professor Deaton. They were yours in your testimony. Well, my time's running out, so I just want to close and say I think Fed Chair Jay Powell said it best when he acknowledged that those least able to withstand the downturn had been affected the most, and the impact of this virus on the health and economic security of the American people has been brutal, and it's hit Black and Latino families particularly hard. And we can't move forward with a full recovery without addressing the underlying racial inequities in our system. I think we do have the fiscal space right now, and I believe the public will to make those systemic and long overdue changes. We have some bold policies that are ready to go, like the HEROES Act and the George Floyd Justice and Policing Act that we'll vote on later this week. And if we're going to reunite this country and come out on the other side of this crisis as a better nation, Congress must ensure that our recovery efforts include proactive policies to spur not only an inclusive recovery, but inclusive growth and opportunities for all. And with that, I will thank the panel once again for your time and your insights and your expertise. And if there's no further business before the committee, this hearing is adjourned.
Thank you.